Hi, everyone. Welcome back. I hope you had a good break. I hope you had an opportunity to stand up and stretch. I'm an ergonomics geek, and I think that's the most important piece. So we're going to jump right in to our next session because we have a really exciting conversation coming up. Our session is a fireside chat with Daniel Burka. Daniel is a product manager and designer who focuses on solving complex problems in simple ways. He is currently the director of product and design at a nonprofit called Resolve to Save Lives, and he works on an open source global public health project. But before that, Daniel had roles within high-profile Silicon Valley companies. So our conversation today is going to focus on what it looks like to design products and services in both of these ecosystems. So Daniel will share learnings, similarities, differences on how design is utilized and what we can learn across these different areas and apply it to our work. Welcome, Daniel. Thank you so much for being here.
Hi, Marina. Thanks so much for having me. It's great to be here.
All right, so I'm going to first jump in and ask you to do a little bit of an introduction and some context into your background and your work.
Sure. All right, so I'm older than I look. So I've been in tech for about 23 years. And I grew up in a little place called Prince Edward Island in Eastern Canada. And my brother and some friends and I started a design agency called Silver Orange there that's been around now for 22 years. Still in business. I'm very proud of this. And we started off really young, just learning by, this before there were great UX programs anywhere. And we learned just by kind of seeing what other people were doing on the web. So a lot of inspiration from people like Dan Cederholm and, Jeffrey Zeldman online, and just started making websites. And eventually we worked on some interesting projects. Like I worked on the original Mozilla website and the brand for Firefox through a volunteer project with the Mozilla group. And then I moved to Silicon Valley and worked at some startups. I was a creative director at a website called dig.com, D-I-G-G.com, if anyone remembers that, for about 5 years. I left Dig and joined the team that became Slack. So if anybody doesn't know this, Slack was originally a game, and I was the director of design on that game. I left that and started a company that my friend and I sold to Google. And from there, I worked at Google's venture capital arm. So I spent about 5 years at Google Ventures. And that was a really interesting role because we got to work with all of the portfolio companies that Google Ventures was investing in, which we're investing enormous amounts of money. I'm from rural Canada, and we're investing like $500 million a year, every year, into startups. And I got to work with a ton of them on their design challenges. And it gave you a huge breadth of kind of what was going on in the industry. And the team I was on at Google Ventures, there were 5 of us, and we published a book called Sprint about design sprints, which is like a methodology, like a human-centered design methodology for testing ideas. And then I left all that and came to a not-for-profit, and that's what I'm doing now.
Awesome. Thank you so much for that retrospective. So tell us a little bit more context also about the project that you're working on now, the nonprofit and then the primary product.
Yeah. So when I was at Google Ventures, I'd been there for a few years, and I met, through a mutual friend, I met Dr. Tom Frieden. So Tom was the former director of the US Centers for Disease Control, which is obviously a very important institution in America for public health. Before that, he was the director that ran the New York City Health Department of Health and Mental Hygiene for Mayor Bloomberg. So he's like a global health expert in public health. And Tom, in the first 2 minutes on the call with him, he tells me that their goal is to save 100 million lives from cardiovascular disease and to work on preventing epidemics. And I was like, dang, I've worked with some ambitious people, and, it's just Silicon Valley, you hear a lot of people saying audacious things, but what Tom was talking about sounded really exciting to me. And so now I work with Dr. Frieden on a technology team that supports huge public health initiatives. So the the majority of my work is on hypertension control programs. So hypertension, high blood pressure, is the biggest killer in the world. It kills more people than all infectious diseases combined, kills more people than cancer. So hypertension is the leading indicator for heart attacks and strokes. If you can help more people to have their blood pressure below 140/90, you could save a lot of people from heart attacks and strokes. We have pretty good evidence-based methods for doing this, but to apply them at scale in places like India, Nigeria, Ethiopia, China is quite challenging. And what you need to do to succeed is a whole bunch of public health things. So you need to choose a simple treatment protocol. You need to train a lot of staff, health staff to treat patients to protocol. You need to distribute care down to the community level. You need to acquire enough medications to support a program. But then fundamentally, you need a system of record that helps you to see where your program is succeeding and where it's struggling and why. And traditionally, this has been done in many places on paper. But paper doesn't scale well to non-communicable diseases like hypertension and diabetes. In India alone, there's 200 million hypertensive patients, people with hypertension. And so we thought a digital system would be really important in order to manage such a program. And so I basically helped develop the world's simplest electronic health record. It records almost nothing, but it's really quick. And that's really important in the context of healthcare in places like India, Bangladesh, or Ethiopia, where a typical clinic visit is less than 2 to 3 minutes.
Thank you. That is all such amazing background, and I appreciate you setting the tone for that context, because I think it's kind of really relevant to what it looks like to do design in these different settings. When we had originally met and in preparation for this chat, what the thing you said about scale and ambition really stood out to me. And even how you said it, when you were like, we think we're ambitious within design because we want, a million whoever is served in whatever context. But to kind of look at this in a global perspective and to reframe what ambition really looks like, to me, that's kind of a reflection of the power of design from a different lens. So I'm curious about this idea of ambition within the entire ecosystem. What does that look like in this kind of massive global public health space, and how does it differ from Silicon Valley?
Well, I mean, obviously the biggest difference between the ambition in a not-for-profit like Resolve to save lives and the ambition in Silicon Valley is it's not primarily dollar-driven, right? I worked in venture capital for 5 years. I'm not going to sugarcoat this. Venture capital is at the gears of capitalism. It is very basic. Somebody gives you some money, your limited partners, you invest that money, and you want that money to come back tenfold. It's quite simple, right? And so when you hear people being ambitious in Silicon Valley, it's like, how can we sell more widgets? How can we get more users so we can sell them more ads? It's quite focused that way, right? If you want to spin it positively. In public health, it's a harder metric, but the idea is to measure lives saved. It's a kind of an upside down metric. How do you record something that didn't happen? But it means that you're not primarily targeting a specific market, if we want to use capitalistic terms. The goal is to help the greatest number of people possible. And in a country like India, that means we can't just work in the easy places. If I work with some Indian startups, and the first thing Indian startups do is they work in what they call in India tier 1 or tier 2 cities. And that means the big cities you might have heard of, places like Bombay, Delhi, Bangalore, Chennai. Those are tier 1 cities. They're well established, have good infrastructure, have huge populations. If you want a hypertension control program that's going to have a big impact, and think about scale, what you need to do is get into the thousands of villages where the bulk of Indians still live. And that means you have to think about the kinds of devices people are using, the kinds of experience they have with technology. You need to really, think very closely about design tools, not just for people like you. And that's where we use user research, user-centered design methods, lots of communication with users, strong support systems, training like large-scale training programs to be able to scale significantly. Like just in the last month, we launched in 1,000 new hospitals. It's crazy when you think about it. Like we have 35,000 healthcare workers using Simple on a monthly basis right now. I went to a Chelsea soccer game the other day in London. There were 35,000 people in the stadium, and you look around, you're like, that's a lot of people.
Yeah, and all of those people have the ripple effects of the people that they touch.
Yeah.
I think that's beautiful. So one of the things, kind of piggybacking off of that, one of the things
you
that
say beautiful, I think it's so much pressure. All those people, they're so busy and they've got such hard jobs. They're all overworked, and they didn't come to work to do data entry. They came to work to treat the patient sitting across the table from them. And, in many ways, I'm getting between them and the patient. It's important for the health program, and they want the health program to succeed. But there's this really interesting push and pull between, why the incentives of what a patient needs, what a clinician needs, what the public health experts need.
Yeah, actually, that's a really good transition to what I was going to ask next, which is this. So we always talk about buy-in at different levels, right? Buy-in specifically for the design process. And I think in public health, what's very part of the reality is that there are a bunch of experts who are the top of their field. They're kind of, they've been doing this thing. They're highly, highly trained. And then there are these designers coming in and kind of introducing maybe new ways of thinking to them, but kind of adding that layer, like you said, getting in between them and the work that they already do. What does the buy-in process, or what has the buy-in process looked like at various spaces within the stakeholders of your project?
Right. So the interesting thing in public health is it's not actually the clinicians making most of the decisions. It's public health officials, usually in the capital city, right? And those people are doctors. They have been clinicians in the past, but they haven't been clinicians in a really long time. And they almost, it's been a very, very long time since they worked in, say, a small rural primary care hospital. And so it's really interesting that you've got this kind of four groups that are making decisions. You've got the public health experts at the top. They're at the Ministry of Health or at important institutions within a country. And they're the ones usually setting the agenda. Then you've got the healthcare workers who are on the ground, have to deal with the real context of being in a very, very busy, overworked, under-resourced clinic. Then you've got the patients. And it's very surprisingly easy to forget the patients. And the patient, often rode the bus for an hour to get to the hospital. They stood in line for another hour to get inside. Then they're sitting in a hallway with other sick people for an hour before they get their blood pressure taken, told they have a disease that they're asymptomatic. They never even knew they had it. And then they're expected to come for follow-up visits every 30 days and stand in line again, right? And then there's the technology team who understands the constraints of technology. So the real trick is to bring all of these groups together to make decisions. And this is very, a bit unusual in public health to include, especially including clinicians in the actual decision making. And there's kind of two ways you can do that. You can bring them into the room at the fundamental outset of the project. And I just did this last week. We're doing a big workshop with the Ministry of Health in Nigeria. And it was great. They invited 3 nurses to the room and gave them the space to speak without judgment, which was really, remarkable. You don't see that very often. And then the other trick is user research. The nice thing is public health people aren't jerks. Like they don't intentionally want to overwork healthcare workers. They're just very curious. So they'll be like, oh, I'd love to measure these 15 things. And they've rarely worked with technologists who remind them that if I need to record those 15 things, it's going to require 3 minutes of data entry in order to generate, the reports that they're after. But the clinician only has 2 minutes. You ask him to do 3 minutes of entry during a 2-minute visit. And so what you're going to do is get garbage data in and garbage, reports out. And so if you're able to bring that loop around using user research or, especially user research, I guess, or bringing people into the room, you can really get people to pare things down into what really matters and then balance out, can we get the data that's important for a clinician to treat a patient so they can treat their patients better? Can we use that same data to inform the public health program and find the intersection where as much of that data is the same thing so clinicians don't feel like they're entering data that just goes up to the government and never comes back to benefit them?
Yeah. Interesting. It sounds like they're pretty open to understanding that whole journey enough to be able to make decisions around it. That's what this might take away.
I think I've been maybe fortunate to work with health programs who think this way. And I think the non-communicable diseases, so diabetes and hypertension, the challenges are particularly acute, right? Because this is very high volume care. Like an individual nurse in NCD clinic will see 100, 120 patients in a day. And so it's quite easy to tell them the story that like, hey, like if you ask for 3 extra pieces of data, multiply that over 120 patients a day, 350 days a year, that's a lot of people, a lot of time. And that makes sense. Whereas if you're working in, say, a TB program or something where it's 2 orders of magnitude less patients, it's a little harder to have these types of this push and pull.
Yeah. What do you think about the idea of the value of design work? Is it, we have kind of ways of showing the value of design or evaluating. What does that look like on the private sector side versus the private sector side, evaluating the value of design work?
Right. Obviously, design work is a broad term, right? Like, what is design? In Silicon Valley, you see a lot more startups that are focused on kind of higher order design, things like brand, things like, if you're competing in a busy space that already has quite a few players, your differentiation can be things like kind of advanced user experience, delight, kind of the really, things like Stripe, where you see both fundamental design and this kind of amazing marketing kind of design. In public health, it's almost all fundamentals. The healthcare workers are very used to using very clunky tools. And so you can really differentiate just by having a tool that's not super hard to use. When the first interviews we did in India, so I joined Resolve almost 4 years ago. And the first thing I did, within the first week, I got on a plane to India. And we spent time with clinicians. And you ask 10 clinicians, what can we do to make your job better? 9 of them will tell you, literally will say, use the words, don't make my job harder. So when we think of design there, it's both just fundamental interaction design. How can we help you do something hyper efficiently? Because it's so repetitive and so needs to be so high speed. And then also the extreme fundamentals, like what fundamentally are we measuring? Because if design starts after that part, right after the kind of the fundamentals are set, you're set up to lose. Like with Nigeria, for instance, we're just kicking off this project with the Ministry of Health in Nigeria. And I spent 2 days last week in a workshop with the ministry, a local diabetes program, my public health colleagues in Nigeria, and so a few other health experts. And did we do design? No, we didn't like prototype anything. There's nothing visual to show from it. But what we did is we set the primary indicators that we're going to have to report and the data elements that are going to be collected in order to drive those indicators. I would argue that is like first order design. Like that is, where good design starts is by setting the basic foundations to make sure that you can succeed in the future. I'm sure a lot of people would argue that that's not a real design job, but I'd be happy to debate them on it.
Well, it's the hidden part of the design process, right? That we don't talk about. I feel like these are kind of the things, to me, these are kind of aligned with similar things like doing some of that interpersonal work to let go of biases, or kind of, it's just things within the cracks of design that I agree with you. I think that should be formally part of the design process. Because we do it, well, if we do it right, we do it anyway. I will say not everyone does it anyway, but yeah, I agree with you.
And I think one of the challenges is, if I can keep going on this point, because I think it's interesting.
Please do.
Is
yes.
I think when people say it's not design, what they mean is like, well, should designers be the ones making the decisions? And no, they shouldn't be. Like, this is a public health decision, right? Like, I actually don't think, you shouldn't let Daniel make your decisions for what to measure in an NCD program in Nigeria. Like, definitely not. But together, we can solve the problem, that works for, all groups. And that's really, like when we worked on design sprints at Google Ventures, the real magic of a design sprint is it has very little to do with design. It almost all has to do with getting the right mix of people in the room who 90% of them aren't designers. But together, that's how good design ends up coming out.
Yeah, absolutely. And actually, you're on point with the transitions. I think one of the other kind of elements to this that came up, so it's on my Q&A list, and it came up right now in this pre-chat as well, is you had this great article about who gets to do design and what's kind of the designer's role versus everybody else's role. And I think that as we talk more about what it really looks like to democratize the design mindset and the design actions, and infuse that so that it's something that carries on long after we're away from the project. I think that comes up especially here, where when you're, whatever it looks like, whatever beginning and end there is to what you're working on, what does it look like to infuse that design process mindset within specifically that group of people?
Right. Yeah, absolutely. So I think very much about how to bring along design into the work of everyone on the team, whether they're, our chief medical officer, our public health teams, our engineering teams. I want them all to be better at design than when we started the project, because it means that we'll all succeed together. And the biggest, I think, learning that we're trying to drive into all of the teams is the value of user research, of actually testing ideas with your real users in a way that will generate reliable results. And so, it was really great, when we were working in Nigeria, for instance, that two things happened. First of all, the engineers, they pushed themselves that we're going to do what they called user acceptance testing, and they really meant user research. And I was just thrilled that it came from them instead of from me. Because we had run a previous process like this, and they were like, okay, so the first thing we're going to do is obviously make a quick and dirty prototype and then try it with real healthcare workers. And I'm like, yep. Great, I'm glad you're valuing that part of the process, because that's where the source of truth will be. And then the second thing is, after we finished, one of our public health team, this guy, Dr. Joseph, he was like, hey, can I join the tech team? Like, can I be one of the designers? And we're like, welcome aboard. Like, you can call yourself whatever you want. And it felt good that he wants to be kind of aligned with us and thinking like he's together with us on the ship, and not just like our client. And that really shifts the mindset that we're solving this thing together.
Yeah, I love when that comes from, that enthusiasm comes from the other side, and you don't have to sell it as much. What's been your favorite part of having made this jump from the kinds of projects you worked on to going into this public health space?
Yeah, I mean, my favorite part is designing tools not for people like me. I did some of that at Google Ventures, but you still do a lot of like tools for technologists, tools for consumers, like American or European consumers. And working primarily in India and Bangladesh and now Ethiopia has been eye-opening. I mean, it's really great because it really lets you take a lot of the processes you've used before, but like flex them in a way that is I guess it's really educational for me you know, I've tried to make simple tools before, but like creating a tool for somebody who's that busy, who, you know, the nurse, she didn't come to work to do data entry. She came to treat patients, and then she wants to go home to her family, and she doesn't want to feel stressed out at the end of the day that the data didn't get synced and didn't get saved correctly. Solving problems for her is very, very interesting and gratifying. You know, when you can go into a clinic and talk to the staff and they don't hate the software you made for them, it's really gratifying. Because you're managing, you know, 1.15 million patients now. I mean, it's a huge responsibility, and when it works, yeah, it feels great.
Yeah. So we have a couple of minutes, a few minutes left, and I know you're jumping into another talk at another conference after this. So I want to make sure we end on time. So a lot of people kind of, people who, you know, work in design, there can be this drive to wanting to work in like public sector, kind of these other types of kind of projects that have a different impact outside of the capitalist realm. Am I allowed to say that? What advice would you give to someone who wants to cross over from working in for-profit to nonprofit in terms of all of it? I'll leave it open-ended.
Sure. I can't speak generally about not-for-profit work. You know, I really have this, you know, I have a couple of experiences under my belt. But the biggest one, especially working in public health or, you know, an environment that's not explicitly about technology, is don't forget that you're kind of back at the pioneering edge. You know, you have to remember it's like when you're at the beginning of your career and like you literally don't speak the same language as the people you work with. Like I'll say words like research, and all the medical people's like antennas go up because they're like, oh my God, we need institutional review boards. And I was like, whoa, we're just talking to some healthcare workers. Like this isn't like research. But there's 1,000 things like that. And they don't, you know, they keep asking questions that we think are quite basic, like when will the software be done? And you're like, the software is never done. Like, that's not how it works. So you have to invest the time and have the patience to remember that, like, you have to bring them along and help them understand how modern software gets made and how software tools get integrated into the public health program. Because that's another big challenge in public health is there's this idea that we'll run the public health program and then we'll have technology. And you're like, it's not, you can't just silo it. Like if the technology is going to succeed, it's got to be an integrated part of a complex program. So yeah, you're going to be frustrated. You're going to have to learn a new language. You know, I've had to learn 300 acronyms in health. But if you're patient and remember it's a marathon and not a sprint, it can be really gratifying.
Yeah. So I'll ask one final question to wrap. And you said something that is always top of mind for me when it comes to a journey of doing design, not just a journey of designer, but it's this idea of being first. And, you know, you've been kind of ahead of the curve on a lot of trends, or even set some of the industry standards, like with your book about sprints. And I'm curious, what is it like to kind of be the first in things all the time, and how do you mentally, or be kind of the future? Oh, you're making a face.
Oh, I'm going to push back on that.
Okay, tell me.
Sprints are built on top of like old ideas, like IDEOs, you know, design thinking, and that's built on top of workshopping ideas from previous groups for decades. A lot of the stuff I've done in tech is building on ideas that came before it. And particularly in public health, I'm hardly the first person to try to solve public health problems in primary care in places like India. There are lots of people who spent decades on this who don't get to speak at conferences. You know, and they didn't make money in Silicon Valley, and like, you know, they don't get nearly the due they're worth. So I want to be real clear about that. And what we're doing here is not rocket science. It's good ideas borrowed from other apps and other tools. Like we went to India first, and we looked at how a system like eHealth Kerala, or there's this great TB program was made called 1MG, I think, that was being made by a group in Bangalore. So really learning things from them. So I push back against the whole idea. Like, I almost never want to be on the bleeding edge of my career. There are lots of designers and they always want to be inventing like the crazy new thing. The best ideas are usually not that radical. Like Twitter, for instance, it was just like sending a short message to your friends. Like, it certainly didn't look radical at the time. It was a good idea. It was simple, you know?
Yeah, I appreciate that. All right, I appreciate that pushback. I think doing new things, maybe, or doing things different. I'll have to think about that. Ooh, you have challenged
Small twists on
kind
old
of the
ideas.
narrative around.
It's very powerful.
Yeah. I think there is. I agree with what you're saying. I think there is a little bit of that narrative in design where it's new and breakthrough and kind of maybe different things applied to a space that makes it new in that intersection, in that context. Right. Yeah, so I'm taking away from your answer that nothing is ever new, and that's kind of helpful in the journey of working on that, because you're building off of something and off of things that already exist.
Yeah, and those things rarely get the press.
Space.
It's like people always want like 3 MIT students made an app that solved COVID on the weekend. Like that story makes the press. The people who put in a decade of work, working on a voting system, there's no article in the press about them. It's not exciting, but that's really where change happens.
Yeah, I think that's a good takeaway for today. Maybe I want to throw this out as a challenge. Let's think about, I want to do this myself. Let's think about the things that we're working on and kind of look at who and what are the foundations of that. And what does it look like to reframe that dialogue? Well, thank you so much for this. We're at time, so I want to let you get to your other conference, but thank you for your generosity with your thoughts and ideas.
I really appreciate you having me here, Marina, and service design is so interesting, and really thrilled to be here. Thank you so much.
Wonderful. Thank you. Thank you, Daniel.